of judges here, not paucity of contestants. So we start the session. Dr. Vikas Sharma. So first speaker will be Dr. Vikas Sharma. He will be talking about a novel surgical technique and an innovative implant as canalicular stent. He hasn't come. He is not taking the phone. I've talked to the office. Office has asked me to start. Yes. Yes. A novel surgical technique and an innovative implant as canalicular stent for post-traumatic repair.
Good
Please.
afternoon, one and all. Trauma can affect the anatomy in such a way that normal standard surgical procedures might not give you the desired results. It may further compromised by lack of resources, and then the innovation comes into play, and innovation is a key to paving surgical advancement and success stories. Herein we present a novel surgical technique and an innovative cost-effective implant for canalicular stenting for its post-traumatic repair. My patient is a 2-year-old child who came with alleged history of injury to the right eye with an iron wire while playing. He presented with pain and bleeding right eye. On examination, his visual acuity with Allen's preschool chart test was normal in both the eyes. An 8 mm partial thickness laceration of upper medial eyelid was noted, and with an intact posterior lamina. On closer examination, upper canalicular tear with a retraction of medial part of the canaliculus was also present. We did an urgent intervention. We taken up this kid for GA surgery under general anesthesia. This was our instrument tray. We used a 26 gauge IV cannula, also a 27 gauge metal syringing cannula, McPherson forceps, and A2 bicameral suture. This was the initial presentation, top left picture. We did probing first, and then this plastic tube of 26 gauge cannula was inserted over this metal cannula. Then the whole assembly was introduced in the upper tone canalicular lacrimal passage, and once the tube was inserted inside, then we used a McPherson forceps, held the tube there and retracted back the metal cannula. Then we made sure that the distal end of the stent is inside the lacrimal sac. We did the canalicular repair, following which over this particular stent with the help of A2 bicameral suture. Then we did the lid suture in the layers with the same suture. Then we secured this plastic tube with the help of a Prolene suture with the lash line. And then when we checked for the patency, it was patent. This was the immediate post-op result. As clearly seen, the tube is away from the cornea and well in situ. This is post-op 6-week photograph. We removed the tube, and sac syringing was also done. It was patent. There is minimal scarring. To discuss, eyelid injuries can be partial or full thickness. This is a significant subset of facial trauma and most commonly occur in children and young adults. Canalicular laceration may or may not be present. However, in cases of medial eyelid injuries, it should always be suspected. Most common causes in children are dog bites or trauma. There are no set repair protocol for canalicular injuries. However, the fundamental principle remains the same, that an urgent and accurate anatomical repair is needed for the functional patency and the better results. The most difficult part of this surgery is how to locate the medial cut end of the canaliculus. The literature says there are various methods: direct evaluation under high magnification, injecting viscoelastic, saline, or air bubble through the opposite punctum, or using sympathomimetic drugs. What we did in our case was we used a 26 gauge lacrimal syringing cannula for probing. We followed the natural curvature of the lid and the canalicular system. It led us to easy identification of the distal cut end, which was a whitish circular opening with epithelial lining, and then the innovative stent was inserted. There are few conventional implants available, which are Winnie-Monoka or Ritleg or Cowford canalicular implants. However, the easy availability is questionable. There are few cost-effective innovative implants which are already mentioned in the literature are 20 gauge silicone rod, which has a drawback of auto extrusion. 24 gauge IV cannula can be used in adult population. and a 5-proline suture needle was also used. However, it is associated with multiple false facets formation. The principle remains the same, and despite being a zonal hospital in a peripheral setup with limited resources, we wanted to give our child the best of the surgical result to ensure a seamless journey without any ocular morbidity. The challenges in front of us was the pediatric patient, non-availability of conventional implant, how to insert this innovative malleable plastic implant, and limited resources for such a rare and specific injury. The possible shortcoming of our procedure is auto-extrusion, loss of implant, and corneal rubbing by the implant. However, none happened in our case. To conclude, the innovation of 26-gauge IV cannula catheter used as a stent for monocanalicular repair, utilizing a 27-gauge metal irrigation cannula as a guiding tool, can be proved as a significant cost-effective alternate to the monocanalicular stent. This is also an economical alternate for such lacerations. And the innovation is even more relevant and promising for developing countries under large underprivileged population. The further studies with larger sample size can help prove this technique as an alternate. These are my references. Thank you.
Thank you. What is the biggest disadvantage with this device?
So, the biggest advantage is
Disadvantage.
the easy disadvantage. Sir, it could get auto-extruded. Also, it is not very easy to implant this malleable implant inside the torn lacrimal passage, which is already compromised. Sir.
Are you prefer in pediatric age group?
Yes, sir. We did it in a pediatric patient, sir. It was 2-year-old
Only
kid.
in all pediatric, but there is some issues like that. The main cost of the surgery is
Yes, sir.
under GA in
Sir.
pediatric. That's why I'm asking to you. Main problem is the main cost is you are highlighting as a low cost. Is
Yes,
it
sir.
easily available?
Yes, sir.
But nowadays, it was an earlier era. Nowadays, everything is easily available in all over India
True,
because
sir.
some India brands are there. So there is one criticism over there. Moment we are doing under GA, the cost is roughly around 15,000, including the anesthesia charges minimum. This is
Yes,
the
sir.
norms.
Yes, sir.
So is there any justification? Because if the tube fall or it is displaced, in such cases you are investing 15 to 20,000 extra, but to save, say like 4,500
So
or
we are
2,000.
not saying, we are not commenting that this particular, in case of non-availability of pneumonoca stents at that particular point of time or in a remote location, then as a temporary measure or maybe in the first procedure when you want to give you the best of the surgical result,
Yes.
then if you don't have anything available at that point of time, then you can use these kind of implants.
Yeah. But your answer should be in a government setup.
Sir.
In government setup, GA, OT surgeries, everything is free, only the stent is not available.
That's correct, sir.
Okay.
So we are in a government setup, hence we had to do it.
Yes,
sir.
yes.
Okay, thank you, Dr. Vikas.
Thank you.
I'm calling Dr. Mohammad Hamid Anwar. He has other preoccupations. So,
Good afternoon. My paper topic is observational study to determine the prevalence of dry eye disease in newly diagnosed depressive disorder patient. Dry eye disease is a multifactorial ocular disorder characterized by insufficient quality and quantity of tear to maintain the normal health and function of ocular surface. It often leads to discomfort, visual disturbance, and potential damage to the ocular surface. While the etiology of dry eye disease is complex and involves various factors such as age, gender, environmental condition, emerging evidence suggests a potential link between mental health condition, particularly depressive disorder, and
First one,
prevalence of
second
dry eye disease. Research has indicated bidirectional relationship between mental health and ocular health, emphasize the need for comprehensive understanding of the potential comorbidity associated with depressive disorder. Aim and objective of my study is to determine the prevalence of dry eye disease in newly diagnosed depressive patient without any previous medication. Material and method. Hospital-based cross-sectional observational study. The study was conducted over a period of 6 months. The study was conducted at Psychiatry OPD of Katihar Medical College, Katihar. Inclusion criteria include patient diagnosed with depression by the psychiatrist, patient no prior history of medication, age more than 18 years, willingness to provide informed consent. Exclusion criteria: patient with history of antidepressant or anxiolytic medication, individual with pre-existing ocular conditions such as glaucoma, cataract and diabetic retinopathy, patient with history of ocular surgery in past 6 months, individual with systemic disease affecting ocular health, pregnant or lactating women, individual with history of drug or alcohol abuse. Sample size: total 100 patients were selected from the psychiatry OPD based on inclusion criteria. Methodology: the study involved the selection of 100 patients diagnosed with depression classified as having mild, moderate, severe depression by the psychiatrist. On the same day of diagnosis of depression, patient underwent a complete ocular examination before initiation of antidepressant therapy. The ocular examination include visual acuity assessment using Snell chart, intraocular pressure management, fundus examination and dry eye test. Dry eye test included tear film breakup time, tear film meniscus height, ocular staining, ocular surface staining with fluorescence, schema test and slit lamp biomicroscopic examination of eyelid margin and meibomian gland orifice. Additional factors such as expression of meibomian secretion and blink rate was also noted. The result of ocular examination were analyzed and study followed the patient for duration of 6 months to observe any changes in ocular health and potential impact of antidepressant therapy on dry eye symptoms. Result and analysis. Incidence of dry eye: among 100 study population, 42% had dry eye, 58% did not have dry eye. The incidence of dry eye disease is 42%. According to age and dry eye, the table presents distribution of dry eye disease come among different age groups. The highest percentage of cases were observed in more than 50 year of age group, that is 22 cases with a significant age difference. According to gender and dry eye, the distribution of dry eye case categorized by gender, female constitute a higher percentage case, that is 55.5% compared to male 45%, with a notable gender difference in prevalence, as 58.2% female were affected by dry eye disease compared to 22% of male. Distribution of dry eye in various tests. Severity of depression versus dry eye. Out of 100 study population, 38 patients belong to mild depression group, 35 belong to moderate depression group, 27 had severe depression group. In that 38, 5, that is 13.2% patient had dry eye. In 35 patient, 17, that is 48.6% have dry eye, and in 27 patient, 20, that is 74.1% have dry eye. Discussion. Dry eye illness is frequently observed in individuals with arthritis, thyroid eye disease and compromised overall health. According to several studies, dry eye disease is more prevalent in women than in male, especially among individuals aged 50 to 52, which correspond to the menopausal age range. During menopause, there is hormonal imbalance between androgen and estrogen hormone, which are essential for the production of lipid layer. The absence of these hormones can result in condition of dry eye. The prevalence of our study is 42%, which aligned with finding reported by Nandini et al. In 2007, Titiska et al. Conducted a study in Turkey. The research assessed the frequency of dry eye illness in untreated patients diagnosed with depression. They attribute this phenomena to the presence of serotonin receptor in the conjunctiva and its close proximity to the meibomian gland. This serotonin receptor have a role in production of tear film. The occurrence of dry eye disease illness could be attributed to the lack of these receptors, which is commonly observed in individuals with depression. It demonstrates that newly diagnosed depression patients are also susceptible to developing dry eye illness, and it not solely causes by the usage of antidepressant. Conclusion of my study is, the study clearly demonstrates that depression itself is a direct cause of dry eye illness. Independent of the usage of antidepressant medication for the treat depression, failure to prompt diagnose and adequately treat dry eye can lead to severe problems such as corneal melting, perforation and ultimately vision loss. Psychiatrists must consider this factor when prescribing antidepressant medication can worsen dry eye disease. It is advisable for psychiatrists to refer patients for prescribing for dry eye disease upon diagnosed depression. This approach helps prevent complication and enhance overall quality of life. Thank you.
What is the for with a dry eye psychiatric problem? Because on and you are mentioning some datas, so those percentage is with a psychiatric problem with a dry eye. How can you assess that patient is not a pre-existing any psychiatric or depression? How can you identify basically to that it is due to the dry eye?
Sir, on the basis of psychiatry OPD, patients were divided into mild, moderate and severe depression group, and patients who are taking already antidepressant medication, these are excluded in my study.
It's fine, okay. So you are basically want to say that is depression patient is suffering from dry eye?
Yes, sir.
Or is it in a vice versa? Because they are not taking care in the lead. Which one, how can you justify? It's a good study, of course.
Because sir, antidepressant itself, because antidepressant drug that work on the serotonin receptor, which are also present in lacrimal gland. Antidepressant suppress the serotonin receptor, that will also suppress the serotonin receptor which are present in lacrimal gland. That will lead to dry eye.
Okay, thank you.
Thank you,
Good
Dr.
afternoon, all. My topic for today is corneal ulcer a cause of dacrocystitis? No financial interest to declare. Corneal ulcer caused by infection is one of the leading cause of blindness worldwide, second value to cataract, and it is crucial to raise awareness about this condition as early detection and treatment can prevent vision loss. And the aim of this study is to explore the prevalence of corneal ulcer with dacrocystitis, and a study design of this study is prospective non-controlled case series with inclusion of 58 eyes with the infective corneal ulcer, and the study was conducted between February 2022 to September 2023, and in inclusion criteria were patient having corneal ulcer in one eyes and no history of any lacrimal pathology previously. And after the positive diagnosis of corneal ulcer, the syringing of the lacrimal drainage system was carried out before any medical treatment, and lacrimal syringing consisted of punctal dilatation, lacrimal sac massage, irrigation with moxifloxacin eye drop to determine the point of obstruction, if any, and the medical treatment of corneal ulcer is initiated based on their clinical and pathogenic diagnosis, and surgical treatment was performed when the infection could not be controlled by medical treatment with the help of corneal specialists attached to our center. And if there is no progress in the healing of corneal ulcer after 3 to 4 weeks of treatment, we re-examine the nasolacrimal system, and if there are symptom of dacrocystitis, systemic antibiotic for a week, and if there is still no improvement, we perform DCR. And the outcome was very satisfactory, and after 3 to 4 weeks of DCR, the infection was under control and the corneal epithelium was healed. These are few examples. Among 58 patients, 5 were diagnosed with dacrocystitis at the end of 3 to 4 weeks, and one case was successfully treated with medical treatment while remaining 4 required DCR. And we conducted this prospective study to explore the possible link between corneal ulcer and dacrocystitis. Only a limited number of published studies indicate a high risk of dacrocystitis due to corneal ulcer. This is a study from North India by Juhi Khatun. The prevalence of dacrocystitis was 19.5 per 10,000 patients for general population, and the incidence of acquired dacrocystitis was 15 per 10,000 patients. And according to population-based study conducted by Wu et al., the average annual incidence of symptomatic acquired lacrimal outflow obstruction in people above age of 5 years was 0.03%. But in our study, alarmingly, our data shows 8.6% of the eyes with corneal ulcer suffered with dacrocystitis. More importantly, patients in our study had no history of dacrocystitis previously. That is, they were diagnosed with dacrocystitis for the first time only after 3 to 4 weeks of corneal ulcer. And this is the distribution of different isolates. Staphylococcus aureus and fungi are the most common isolates in our all the cases, and typically staphylococci are associated with dacrocystitis, and fungi are related to chronic dacrocystitis in China. And conclusion is corneal ulcer can lead to obstruction of the lacrimal duct, particularly in the lower canalicular region, causing dacrocystitis. And to best of my knowledge, corneal ulcer can lead to lower canalicular obstruction, while dacrocystitis can worsen corneal ulcer by delaying tear film clearance and altering microbial flora. Although various studies have been conducted on the treatment of dacrocystitis and corneal ulcers, but still the scientific community has not yet recognized the association between corneal ulcer and dacrocystitis. Although there are many studies on corneal ulcer causing dacrocystitis causing corneal ulcer. And the take-home message is, while treating the corneal ulcer, please assess the blockage of lacrimal duct. Thank you. And
But it can be done if everyone doing a syringing or proper assessment of the NLDO, then only we can think it it is due to the corneal ulcer, or it may be a vice versa. Either it is a NLDO is responsible for corneal ulcer. In our previous knowledge, it was thought, so NLDO is the main cause for corneal ulcer. But you are now highlighting is, thank you for that, maybe a vice versa, it may be a vice versa, but for any day we proper methodology to assess the patient, then only we can highlight it all those points. So if we do, how many of your patients are fungal corneal ulcer?
Fungal 5. Actually, I want mentioned
And
5.
is there any patients you find it out during the dacryocystitis, it is a fungal element?
I will see the total log portion that I said. Because time was very limited, that's why I
Yes,
have to
yes.
figure out that.
We can look because maximum number in our clinics is a fungal corneal ulcer generally. Then in our setup, in our background, Indian background, than bacterial. Bacterial generally may improve little, those who are attending
As I remember, 1 or 2 cases of Candida. I had.
Candida, yes. So we can rethink in culture all, then it will be a very good study. Okay.
Thank you.
Good afternoon, everyone. My study is on the topic outcomes of lacrimal gland injection of botulinum toxin A in functional versus non-functional epiphora under the guidance of my co-author, Dr. Hariram Ojha sir. There is no financial interest in the subject matter. As we all know, epiphora is known to be excessive tearing caused either by excessive tear production or due to poor drainage of tear. So epiphora is mainly categorized into 2 types, functional and obstructive. Functional, it is tearing when lacrimal drainage system is patent, but obstructive when there is obstruction at any level in the lacrimal drainage pathway. The aim of my study is to assess outcomes of lacrimal gland injections of botulinum toxin A for epiphora secondary to lacrimal drainage disorders and functional epiphora. It is a retrospective interventional study conducted over a period of 6 months. Informed consent was taken from all the patients and irrigation was performed in all the subjects to rule out any obstructive pathology. Schirmer test with anesthesia was performed to rule out reflex tearing. We have categorized the patient into 2 categories: patients with patent irrigation and less than grade 1 fluorescence dye disappearance test and any ocular surface disease, if present, were categorized as functional epiphora, and the other with punctal stenosis, canacular obstruction and NLD obstruction were categorized as non-functional epiphora. There were total 21 patients, out of which 7 patients were grouped under functional epiphora and 14 patients were grouped under non-functional epiphora. In this chart, we can see the various subcategories of functional and non-functional epiphora group. Each patient received a drop of topical proparacaine 0.5% before injection. Here is a video performing as the procedure in which you can see that we have everted the upper eyelid of the patient to expose the palpebral part of the lacrimal gland. We have injected Botox containing botulinum toxin A transconjunctivally. It is 2.5 units per 0.1 cc. Now after giving the injection, we are trying to deposit back the lacrimal gland into the lacrimal fossa. Patients with less than 1 month follow-up were excluded from the final analysis. And these are the results. So in this we can see that the median preoperative Monk score was grade 4 in both the groups, but after giving the injection it reduced from 4 to 1 in functional epiphora group and from 4 to 2 in non-functional epiphora group. And the percent improvement in outcome was 50 to 80% in functional epiphora group, and in the non-functional epiphora group it reduced from 20 to 65% only. This is average Monk score throughout our study period. Pre-injection we have seen that it was grade 4 in both the groups, and after giving injection at 2 weeks of interval we have seen that it reduced from 4.2 to grade 2 in the functional epiphora group, whereas it reduced from grade 4 to grade 3 in non-functional epiphora group. At the end of the 6th month, it was grade 2 in functional epiphora group and it was grade 3 to 4 in non-functional. So there is improvement in Monk score which shows a better trend towards the functional epiphora as compared to non-functional epiphora group. Yeah, the complications were reported in both the groups. There was 1 case of ptosis in both the groups which was transient and completely resolved over a period of 4 to 4.5 weeks. There was need of re-injection in both the groups. 6 out of 7 patients needed a second dose in functional epiphora, whereas 8 patients needed a second dose in the functional epiphora after 5 months only, whereas in the functional epiphora after 6 months. And in the non-functional epiphora, 5 patients showed no reduction in epiphora also. There was no complaint regarding dry eye or diplopia. Functional epiphora has been defined very vaguely in literature, which even includes cases of partial NLD obstruction and also patent irrigation in presence of lacrimal pump failure. These should be categorized as functional nasolacrimal duct obstruction. So, in our study, cases with patent irrigation and no delay in fluorescence diet disappearance tests were included in functional group, thus ruling out outflow pathway etiologies. Mechanism of action of botulinum toxin is the light chain of Botox inhibits cleaves the SNAP25 protein, which is needed for the acetylcholine to release from the vesicle. So its action is at the level of neurotransmitter. In cases with outflow obstruction, reduction in tear production is unlikely to resolve epiphora as a primary etiology has not been addressed. However, in cases of aberrant reinnervation, which leads to increased tear production, botulinum toxin decreases the tear production and can help in resolution of symptom. So the conclusion of my study is that the reduction in epiphora after lacrimal gland injection of botulinum toxin A is seen in both the cases, but the symptomatic improvement was more in the functional epiphora group. The clinical implication of my study is that the botulinum toxin injection in lacrimal gland is a minimally invasive, good alternative for patients with refractive epiphora. It can be performed in an outpatient setting, is technically easy to administer with a favorable side effect profile and a good efficacy viable alternative for patients who are unable to undergo surgery or who have failed symptom control with existing medical and surgical management. Thank you.
Fine. What is the biggest disadvantage with this therapy,
Biggest disadvantage with
this treatment protocol?
So, there can be transient ptosis or diplopia, and there can be dry eye.
No, those are the rare complications.
Yes, sir.
But if you want
So
to
biggest
treat,
disadvantage is that with the time, we have seen in our study, after the duration of 6 months, the effect of the injection reduces gradually.
it's common. That is common. In any case of a botulinum toxin, if you treat as per the company norms, you have to just work 2.5. But in our clinical practice, generally up to 3 months.
Yes, sir.
After 3 months, you have to repeat. There is no other way. Why I am asking the question, what is the biggest drawback of this treatment protocol? As it is a competitive
So,
paper,
yes,
that's why I'm asking.
So Botox is not that cheap, and it costs. Well,
If we compare
everyone
with the
cannot afford.
other,
Yes, sir.
generally in other hemifacial spasm or blepharospasm need 50 unit.
Yes, sir.
If you want to treat in a small setup, it is the biggest disadvantage because 2.5 is required and the minimum vial is 50 unit.
Yes, sir. 50.
That's the point. Yeah.
Yes, sir.
Okay, fine.
Thank you, sir.
Yes.
Thank you.
Everyone, the topic of my free paper presentation is the AI revolution in dry eye diagnostics. I do not have any financial disclosure in this presentation. Artificial intelligence, as we all know, has taken its grasp over the healthcare system, and ophthalmology being one of the most dynamic streams is largely influenced by the AI. The AI-based imaging software has helped in the diagnosis of the dry eye diseases easier. Currently, many studies have come forward with the promising results of the AI-based algorithm in diagnosis of the dry eye diseases. The subset of dry eye in AI in the diagnosis of dry eye is a machine learning which interprets the NIVT and interferometry and deep learning curves for the mammography. The dry eye market is flooded with the many devices like the corneal topography, wavefront aberrometry, inflammadry, to name a few, as it is not feasible for every ophthalmologist to purchase all these devices. That's where the multi-imaging integrated device comes into play. The purpose of our study is to assess the effectiveness of the novel dry eye analyzer created by AI in diagnosing patients with the ocular surface disorder. It was a prospective study done on 190 subjects. First, the patients were sent for the ocular surface disease index questionnaire, then followed by the dry eye analyzer, and then followed by the traditional Shermer and ocular staining. The ability to distinguish the aqueous deficiency or evaporative type is pertinent in deciding the treatment modality. So the dry eye analyzer consists of NIVT, tear meniscus height, infrared mammography, and lipid layer interferometry. NIVT uses the Placido's disc projection and C for the image distortion. First, it gives a breakup time, average rupture time, and then generates a heat map. And tear meniscus height is measured by using an inbuilt ruler in line with the pupillary center. The above two images are showing the normal tear meniscus height, and the lower two images are showing the abnormal tear meniscus height of less than 0.2 millimeter. Infrared mammography uses an autofluorescence of the healthy mebum when an infrared ray falls on it. The first image is the image obtained coupled with the AI coupled camera device, and then AI image is superimposed upon it to see the gland loss. The first image that we can see here is showing the normal meibomian gland, and the second image is showing the grade 2 MZD with the 40% gland loss, and the third image is showing the grade 3 MZD. Lipid layer interferometry is based on the principle that when an adequate bright light falls on an adequate light falls on a lipid layer, there is generation of the interferometric fringes. Thicker layers are denoted by the colorful fringes, and the thinner layer with the colorless fringes. So coming to the result of our study, we found that in Surmer test, 12% of the patient had severe dry eye, and 35% of the patient had MZD2 and MZD grade 3 abnormality, and lipid layer abnormality was found in 42% of the patient. Out of all the patients presented with the signs and symptoms of the ocular surface disorder, we found that 72% of the patient had dry eye. While we plot the abnormalities in a graph, this is how the graph looks like. So what we already know of the multi-modality device is that it is automated nature, non-invasive and less time consuming. But what our study adds is that meibomian gland disease and abnormal lipid layer thickness contributes more than 50% of the cases, and there were certain cases missed by our traditional test. And limitation of our study lies in the fact that monitoring of the patients over a course of time was not done. So what are the translational potential of our study? It is an image-based targeted therapy. This is how the report of a dry eye analyzer looks like. Here we can see the color-coded report. It helps in raising the patient's awareness and compliance to treatment. Using this analyzer, precise monitoring of the response to treatment can be done. Thank you so much for your kind listening. My take-home information is, sir, in a busy OPDs, we can use the AI for easier diagnosis and less time consuming.
Is there any disadvantage?
Disadvantage being, sir, AI cannot detect human emotions, so it might over diagnose the case, and then we might over enthusiastically treat the patient.
Yes, that water intake, the environment in your
Yes,
OPD,
sir, yes, sir.
so AC, non-AC, and patient from which community can that socio-economic condition all may, because it is a air induced.
Yes, yes, it doesn't detect human emotions too.
Biggest disadvantage, and there is a direct role on weather also.
Yes, sir.
Okay, fine.
Okay, thank you. May I call upon now Dr. Priyanka Jadhav?
Good afternoon everyone, myself Dr. Priyanka. I will be presenting a topic of study of dry eye status in type 2 diabetics and its association with the severity of diabetic retinopathy. So as we all know, diabetes is one of the most common medical condition worldwide, and it has a life-threatening or debilitating complication in heart, kidney, brain and eye. So in the eye, diabetic retinopathy, cataract, glaucoma, keratopathy, chronic dry eye and refractive abnormalities are the diseases associated with diabetes. So etiopathogenesis of dry eye in diabetics can be explained as it is related to the peripheral neuropathy secondary to hyperglycemia, insulin insufficiency, inflammation, autonomic dysfunction and altered enzyme aldose reductase activity. Some researchers has also reported that diabetes induced histological alteration in lacrimal gland, hyperglycemia related oxidative stress. So, diabetic retinopathy is a leading cause of visual impairment in working age people, and it is related with the decrease in the perfusion of capillary bed in retina, and neovascularization will be developed to compensate the retinal ischemia. It has been emerging as a crucial outcome measure for clinicians to detect dry eye disease earlier and to look forward treatment in the early stages itself, so as to prevent the further adverse complication of dry eye in diabetic patient. So therefore, this study aimed to evaluate a dry eye disease in diabetic patient and its association with the progression of diabetic retinopathy. So aim and objective of my study was to estimate proportion of patient with dry eye disease in type 2 diabetes patient and determine its relation with the severity of diabetic retinopathy. So it was a cross-sectional study conducted from June 2022 to November 2023 in our department, and the study population was 100 patients with type 2 diabetes coming to our OPD. So we included all the patients with type 2 diabetes and above the age of 30-year-old. Then the patient with ocular disorders such as allergic eye disease, vitamin A deficiency, Stevens-Johnson syndrome, vernal keratoconjunctivitis, herpetic eye infection were excluded from our study. Also the patient receiving any topical treatment, having history of ocular surgery, also the patient having the systemic diseases like rheumatoid arthritis, Sjogren's syndrome and lupus erythematosus and contact lens wearer were excluded from our study. So observation and results includes among 100 patients with diabetes, 57 patients were diagnosed to have dry eye, and out of 58 patients with retinopathy, 45 patients, that is 77% were found to have dry eye, and out of 42 patients with no retinopathy, 12 patients, that is 34% had dry eye. So as we see in the graph, the incidence of dry eye was more in the diabetic retinopathy group. So based on OSDI's grading, 53% patient was having symptomatic dry eye. Out of that, 20% were having mild dry eye, 22% were having moderate dry eye, and 11% were having severe dry eye. So we also found a significant association between the diabetic duration and the dry eye. So in our study, the prevalence of dry eye in diabetic was 57%. In particular, diabetics with retinopathy had higher prevalence of dry eye than the diabetic with no retinopathy. So in our study, the mean age of diabetic with dry eye were 55.45 plus minus 8.32 years. So we also found a significant association between dry eye disease and duration of diabetes in our study. Longer the duration of diabetes, higher was the prevalence of dry eye. In our study, significant difference in T-BUT and Schirmer test was observed in the patient having diabetic retinopathy. Based on the OSDI system score, among 100 diabetic patients, 53% had symptomatic dry eye, and the frequency of dry eye symptom in our study showed significant difference in the OSDI score between diabetic with retinopathy and diabetic with no retinopathy group. So adequate glycemic control could prevent the dry eye disease as well as retinopathy progression in diabetics. So a limitation of our study was limited sample size and lack of more objective tests like conjunctival impression cytology, tear osmolarity measurement. So to conclude, patients with type 2 diabetes have higher prevalence of dry eye. Evaluation of diabetic patients using OSDI questionnaire can helpful in identifying dry eye in early stages. Significant association was noted between dry eye disease and the duration of diabetes. Significant reduction in the T-BUT and Schirmer test was found in diabetic patients, especially in those with retinopathic changes. A positive association was observed between the severity of retinopathy and dry eye. So a patient with advanced diabetic retinopathy are at increased risk of developing ocular surface complication. So hence our study insists that clinical evaluation of dry eye should be an integral part of ocular examination in diabetic patient. So these are my references. Thank you.
Good afternoon, everyone. My topic is the role of mobile endoscope in dacryology. First of all, basic introduction. Dacryology is the science that deals with the lacrimal system of the human body. Lacrimal system incorporates both ophthalmic and nasal system. Ophthalmic part contains whole lacrimal system except NLD, and nasal part consists NLD. So that any treatment of the epiphora cases, successful management, first of all we had to rule out the nasal pathology like nasal polyps, nasal synechia, deviated septum and hypertrophied middle turbinate. What we are doing to rule out the nasal pathology in OPD, we are using the traditional nasal speculum, but there is a lots of limitation with the traditional nasal speculum. What is the restricted field of view? We can see up to anterior nares only. And another one is not able to document a counseling to the patient. We cannot show the pictures to the patient. This is the problem you have. And in cases we want to document, in further advancement, we want to examine the nasal evaluation, we go in the OT and we are using the traditional nasal endoscope. But here is also limitation. This is the non-portable. This is the setup, fixed setup. LED screen and endoscope is the fixed there. We can't move it here and there. And another is expensive compared to our next endoscope. It is expensive. So that I have tried mobile endoscope. This is now using as the otoscope in the market, and it is freely available at the e-commerce sites, and people are using, and ENT surgeons are also using as a otoscope. This is the LED pen-like light which is attached to the mobile computer, and easily we can use it at the nasal endoscope also. And what is the benefit of this one? This is the wide range of view. Able to document, we can save the pictures and we can show to the patients and its attendants. It is portable, it is pocket friendly, we can take in the pocket. And it is very cheap compared to the traditional endoscope. Then we have decided to find out this usefulness of mobile endoscope in our dicryology as a ophthalmologist for the diagnostic and therapeutic purpose. So that we have done an observational study in REH Gorakhpur from May 2032 to December 2024 in adult patient with symptomatic euphoria. First of all, diagnostic purpose, we have 31 patients, 13 male and 14 female. And out of this, 25 patients examined in the OPD and 8 patients examined in the OT. Mean age was 52 years. And after that, for therapeutic purpose, we have chosen failed DCR cases and CNLDO cases. Total number of patients are 8. Out of this, 3 is the female and 5 is the female, and 3 is the male. And among them, 50% CNLDO cases and 50% failed DCR cases. This is the method how we are examining in our OPD, and how beautiful view we are getting, and patient and attendant also getting the beautiful view of the nasal evaluation. And if any problem, we can show them and we can document, we can save the pictures and send to them. Just patients are sitting on the OPD table and mobile endoscope is attached to the camera holder is there, and we are performing our procedure, and you can see up to the not posterior but better view of the inferior turbinate, middle turbinate. We are not getting view of the anterior turbinate, but middle, and our main site of interest is the middle turbinate. We are getting the better view, and result is the OPD screening 20% within normal limit, 5% roomy nose, and 8% at DNS. All DNS patient OT screening done. Out of that, 2% had nasal synechia, 3% had the severe DNS, 3% we are not able to do. In the therapeutic cases, result is the one patient we have relieved the failed DCR cases by the mobile endoscope, but out of 3% we relieved by the traditional endoscope. In the CNLDO cases, out of 4 cases, 50% we are able to find the probe, view the probe, and 50% we are not able to visualize the probe. So conclusion, we have decided into 2 parts, pro and cons. What is the pro part? First of all, is the cost effective, so that every ophthalmologist can try to learn the endoscope. It is portable. We can use it in the remote campus also. It is better alternative or traditional nasal endoscope for screening and pre-op examination. Cons is the image quality is not good as it is limited use for therapeutic purpose. Need to do more observational study by different hands to understand this usefulness in dicryology. Thank you.
he mentioned there is a lots of issues,
Yes, sir.
lots of issues on because the quality, I think, one
Image
of the
quality is
image
the-
quality
yes.
and
Say-
the depth perception. I
Depth
think.
perception and image quality, and we not able to approach the anterior superior turbinate. We are able to, our area of interest is the mainly middle turbinate.
Middle terminal.
Middle turbinate area of interest, we can see the middle turbinate, but lots of patients coming to the ophthalmologist, we are not able to see the nasal part. What is going on to the nasal part? We are referring to the ENT surgeon, ENT surgeon, patient are coming back, sometimes not coming back.
Yeah, that's one, that's technical, but in most of the ENT surgeons also doing an anterior rhinoscopy only. Maximum number in some district level, those are working at district level, they don't have that endoscope, that's a big issue. They are doing that still anterior rhinoscopy, so it's a alternative over that.
Alternative, sir. This is for the OPD screening, remote campus. We have also traditional endoscope, but we have to go to the OT. In the BG OPD schedule, you can use it if you are thinking like that some nasal pathology is there, deviated, or something is there. We can use in the OPD, send to the remote campus and do the screening and send to the our higher center. For
What is the cost?
cost is 2,000 to 3,000. But this one is a gifted for me.
I think the image quality can also be
Yes,
upgraded.
but no, setting is not there, sir. There is only one setting, increase the light.
No, I think the later on it can be upgraded also.
Yes, yes, this one is given for the trial to me.
Yeah.
Ki you check it, ki what is the pro cons is there, and according to that we can change it
They will
in the setting.
develop later on.
This. Yes, sir. OPD and camp. Nothing else,
Rapid
sir.
screening procedure.
Yes, sir. Rapid screening procedure.
Thank you.
Thank you, sir.
So,
Safety, efficacy and outcomes of dacryocytorrhinostomy with circummastual injection of mitomycin C. DCR is the surgery of choice in the management of chronic dacryocystitis and NLD obstruction with a high success rate. However, the failure rate can range from 4 to 13%. The goal of DCR is to bypass the obstruction in the distal lacrimal sac or nasolacrimal duct to restore the patency of tear outflow system. The most common cause of failure is the scarring at cicatricial closure of the osteotomy site. Therefore, increased success rate can be achieved by using antifibrotic agent such as mitomycin C. The source of mitomycin C is Streptomyces cespitosus. It's a systemic chemotherapeutic agent. It inhibits the synthesis of DNA, cellular RNA and proteins by inhibiting the synthesis of collagen by fibroblast. Our aim is to assess the safety efficacy of COSM-MC in external DCR and to evaluate the outcomes. It's a prospective interventional consecutive case study done between March 2021 and 23. 200 patients with PANDO or SANDO underwent external DCR with the COSM-MC after obtaining informed consent and performed by a single surgeon. Inclusion criteria included patients having chronic dacryocystitis, NLD obstruction, previously failed endonasal DCR, traumatic secondary NLD obstruction, and patient willing to give informed consent. Exclusion criteria included patients with acute dacryocystitis, uncontrolled bleeding dyscrasias, prior radiotherapy exposure, patients who are allergic to mitomycin C, and patients not willing to give informed consent. After detailed history and ocular examination, standard lacrimal workup was done with lacrimal syringing, probing and analysis of the puncta and its opposition with the globe and tear film height. Pre-op evaluation was done and ENT evaluation was done to rule out any pathology or abnormalities. CT orbit in cases of trauma or previous maxillofacial surgery was done. Preparation of 0.02% mitomycin C was done, that is 0.2 mg per ml. By mixing 2 mg of MMCVL with 10 ml of sterile water, 1 ml of this dilution was taken and 0.1 ml of this is given at 4 sites of the osteotomy site intramucosally around the osteotomy site after fashioning nasal flaps. Follow-up was done on day 1, 7, week 4, 12 and 6 months. The silicone tube intubation was done in difficult cases like failed endonasal DCR, revision DCR or extensive fibrosis. Functional patency noted by sac syringing and anatomical monitoring done by nasal endoscopy. Anatomical success is defined as the patent lacrimal passage on irrigation and functional success was defined as resolution of epiphora and osteomy is examined for cicatricial closure, narrowing and mucosal health by 1 and 6 months. Results, coming to results, age distribution, most of the patients were between the age of 31 to 40 years followed by 41 to 50 years and there was a female preponderance and most of them presented with watering followed by swelling and post-trauma later. And silicone tube intubation was done in very few patients. Post-op at week 1, 100% patency was noted, and week 4 and week 12, 3% blockage and 5% blockage noted respectively. Coming to results, a total of 200 patients underwent external DCR with mitomycin C. The mean age at presentation was 42 years, ranging from 8 to 75 years. There was a female preponderance with 1:1.94 ratio. The median duration was 12 months. The major complaints was epiphora. The primary nasolacrimal duct obstruction noted in 81.5% cases, and persistent congenital NLD obstruction was 11.3%, and traumatic secondary NLDO is 4%, and revision DCR was 3.5%. The intra-op anatomical success achieved in 100% of the cases. The follow-up was done at 1 month, 6 months and 12 months, and success rate in revision DCR is 91.7%, and in traumatic saldo it was 86.2%. There were no major intraoperative complication except for bleeding in some cases. The postoperative complication of significance but not related to COSM-MC was stent prolapse in 4 of the cases, and none of the patients were noted to have mucosal burns in the area where COSM-MC was injected, and none of the ostia ever showed any feature of necrosis or infections. Except for 10 failures, all the ostia were large at the final follow-up and with good mucosal integrity. Coming to discussion, a study by Khadka et al. Reported failure rate of 3.3%. However, in our study, we had a failure rate of 3% in external DCR with COSM-MC cases at the end of 6 months. Cheng et al. Reported after use of COSM-MC he reported reduced closure of osteotomy site. In our study also we found that COSM-MC is safe and effective procedure. A study by Javed Ali et al. Used both topical and COSM-MC, and it showed profound changes in the nasal mucosa with more marked changes in the COSM-MC group. In our study, we used intramucosal injection of MMC, which resulted in higher success rate. The comparison between our study and study by Saurabh Kamal et al. The mean age at presentation was 42 years, male to female ratio was 1.1:94, and our success rate was 97%. This is the picture showing osteotomy site. And conclusion, our results showed that the use of intramucosal injection of mitomycin C is a safe and adjunctive modality in external DCR. It is very useful in very difficult cases like secondary traumatic saldo, and no complications or side effects were noted during the follow-up period.
Yes, for the literature, what are the side effects of mitomycin C?
It can cause systemic side effects also, ocular side effects also. It can cause scleritis. It can cause
No, as you are wheezing in a necrosis to rhinostomy, in the
it can cause around the nasal mucosa. It can cause nasal mucosal burns, or it can cause infection. But we are using very low concentration, so we can't show any of those features. We use very 0.02%. In the literature, it says 0.05 mg to 0.5 mg you can use.
Did you compare it with other antimetabolites?
That is the drawback of our study. We didn't use any other comparison. We used only external DCR.
Okay, your maximum follow-up was
12 months.
only 12 months. Difficult exactly to know that any side effect, what are the other, or there may be some systemic absorption, and there may be, because it is used basically in a simple cases. That's one of the. No, terrorism is okay. Terrorism, because we can wash it out. But here it goes to the intestine. But here in very rarely we can wash it out. Very few are entering the systemic. That's one of the biggest drawback. Okay.
Thank you. Is Dr. Sunil K here? Sunil Kumar K? And we cannot allow any alternative author to read out the Dr. Deepak Mishra's paper, because no co-author has been.
No, Deepak is there.
No, Deepak isn't there.
Here, he is there. He is not a company.
So I have not been informed that scientific committee is allowing. You are Dr. Deepak Mishra. Oh, so then it's no problem. So I was informed that Deepak Mishra is not competitive. Okay.
No need for any marking.
No. Come to this side.
Good morning. The topic of my respected judges and the topic of my presentation is comparative analysis of surgical technique in large lower lid tumor excision, laissez-faire versus conventional lid reconstruction. I have no financial disclosure. Healing by secondary intention in cases of lid tumors hasn't been preferred by surgeons for the fear of suboptimal cosmetic and functional results. The objective of this study was to examine the role of secondary intention in the healing following excision of lower lid tumors in cases that would have normally required extensive flaps or skin grafts to close the defect by comparing laissez-faire technique with tensile rotational graft for lower lid masses. It is a retrospective study. A comparative analysis of 44 patients was done. 21 patients were taken in group A, which followed laissez-faire technique, and 23 in group B, where tensile semicircular rotational flap was done. Study was done at RIO from January 2021 to January 2023. Follow-up was done on day 7 and at the end of second week, 1 month and 6 months respectively. Comparison of functional, cosmetic outcome and recurrence was done at the end of 6 months. Statistical analysis was done on EPI-Info 7 while variables were analyzed by chi-square test. Inclusion criteria was tumor involving more than 2/3 of the lower lid, including lid margin. Incision biopsy confirmed malignant cases, clinically localized tumor, and size defects of length 14 to 23 mm and width 5 to 7 mm. Sebaceous cell carcinoma tumor with pagetoid spread were excluded from the study. In group A, the incision was given 4 mm away from the clinically indurated area. The mass was excised till 4 mm away from clinically visible extent of tumor and left to granulate by secondary intention. All excised tissue was labeled and sent for histopathological examination to confirm diagnosis and assess tumor clearance. This is a pre-op photo of the patient in which we do the incision marking and the mass was removed. And these are the photos of post-operatively on day 7 on eye closure and at the 1 month. In group B, under the local nerve block, a superiotemporal semicircular flap was fashioned from the lateral canthal area. The flap was elevated in suborbicularis plane up to the orbital rim and subcutaneously beyond that to prevent to avoid damage to zygomatic branches of facial nerve. The flap is raised up to the periosteum and moved medially to cover up the defect. The conjunctiva in the lateral fornix is dissected and advanced to suture the margin, thus forming the lower lid. This is a pre-operative photo of that case, and after the removal of the mass, we can see the post-operative conditions on eye closure and at eye opening at 6 months. Observation and results. In group A, the male is to female ratio was 9:11. In group B, it was 12:11. Mean age was 61 plus and minus 15 years in group A and 59 years plus minus 12 years in group B. 12 patients of sebaceous cell carcinoma, 4 basal cell carcinoma patients, and 5 squamous cell carcinoma patients were taken in group A, whereas 13 patients of sebaceous cell carcinoma, 3 basal cell carcinoma, and 7 squamous cell carcinoma patients were taken in group B. The mean size of lower lid defect along the length was 20.34 plus minus 3.3 mm, and width was 5.50 plus minus 2.5 mm in the group A. And the mean size defect was 21.25 plus minus 3.9 mm, and width was 5.64 plus minus 2.8 mm in the group B. Lateral canthal involvement was seen in 1 patient in group A. No canalicular involvement. All patients were had tumor-free margin, and no recurrence was seen in group A. Outer canthal involvement was seen in 2 patients in group B. Medial canthal with canalicular involvement was seen in 2 patients. 1 patient underwent resurgery for involvement of the margin, and there was no recurrence seen in group B as well. On comparison of post-op symptoms, watering and foreign body sensations were noted more in cases of group A patients rather than in group B. The complications encountered both in group A and group B were scarring with ectropion, granulation tissue, and hypertrophied scar, but they were not significant according to the study. 81% patient in group A were satisfied with the cosmetic results post-operatively as compared to 89% in group B. Discussion. Allowing the wound to heal by secondary intention is a viable alternative. In our series, we obtained a satisfactory functional and cosmetic result in all except 4 cases. Lori et al. Presented a series with a satisfactory functional cosmetic results of 83%. Study by Mehta et al. Showed that 1 out of 11 patients needed secondary repair after excision of lesions involving lid margin. Shankar et al. Reported 92% satisfaction on post-op cosmesis with laissez-faire technique, whereas our study reports 83%. Conventional technique like tensile rotational flap has a learning curve as opposed to the tensile techniques and is more time consuming. It requires added equipment as well. Healing by secondary intention is an effective, safe and inexpensive, easy alternative to primary or stage skin closure in management of lower lid tumors. The limitation of a study was a small sample size and surgery was done by a very expert surgeon with 10 years of experience. These are my references. Thank you.
What are the criteria to seize Group A and Group B? Again, you just Pardon? But in your case, some mention in one of your slides is medial canthal involvement or is it lateral canthal involvement?
The randomly selected patients, one patient had a lateral canthal involvement in group A, whereas in group B we had 2 with a medial canthal involvement and 1 with a lateral canthal.
If you include both medial and lateral, there is a huge difference on surgical plan, etc. So this is the one of the you cannot do a random just a CT collection because medial canthal that is protocol is totally different. Reconstruction and lateral one is very easy in compared to medial one.